This recording will go over Chapter 38, Care of Patients with Acute Coronary Syndromes. Coronary artery disease, also known as heart disease, is a broad term that includes chronic stable angina and acute coronary syndromes. It affects the arteries that provide blood, oxygen, and nutrients to the myocardium. When blood flow through the coronary arteries is partially or completely blocked, ischemia and infarction of the myocardium may result. Ischemia occurs when there's insufficient oxygen to meet the needs of the myocardium. Infarction or necrosis occurs when severe ischemia is prolonged and decreased perfusion causes irreversible damage to tissue. Coronary artery disease is the single largest killer of American men and women in all ethnic groups. When the arteries that supply the myocardium are diseased, the heart cannot pump blood effectively to adequately perfuse vital organs and peripheral tissues. The organs and tissues need oxygen and arterial blood for survival. When perfusion is impaired, the patient can have life-threatening signs and symptoms and possibly death. Angina pectoris is chest pain caused by a temporary imbalance between the coronary artery's ability to supply oxygen and the cardiac muscle's demand for oxygen. So there's an imbalance there of the supply and demand of oxygen. Ischemia, or lack of oxygen, that occurs with angina is limited in duration and does not cause permanent damage of the myocardial tissue. Angina may be of two types, stable angina and unstable angina. Chronic stable angina is chest discomfort that occurs with moderate to prolonged exertion and a pattern that is familiar to the patient. The frequency, duration, and intensity of symptoms remains the same over several months. Chronic stable angina results in only slight limitation of activity and is usually associated with a fixed atherosclerotic plaque. It is usually relieved by nitroglycerin or rest and is often managed with drug therapy. Rarely does chronic stable angina require aggressive treatment. The term acute coronary syndrome is used to describe patients who have either unstable angina or an acute myocardial infarction. In acute coronary syndrome, it is believed that the atherosclerotic plaque in the coronary artery ruptures, resulting in platelet aggregation, thrombus formation, and vasoconstriction. The amount of disruption of the atherosclerotic plaque determines the degree of coronary artery obstruction in the specific disease process. Unstable angina is chest pain or discomfort that occurs at rest or with exertion and causes severe activity limitation. An increase in the number of attacks and in the intensity of the pressure indicates unstable angina. The pressure may last longer than 15 minutes or may be poorly relieved by rest and nitroglycerin. Unstable angina describes a variety of disorders, including new-onset angina, variant or Prinzmetal's angina, and pre-infarction angina. Patients with unstable angina may present with ST changes on a 12-lead ECG, but do not have changes in the troponin levels. Ischemia is present, but is not severe enough to cause detectable myocardial damage or cell death. New-onset angina describes the patient who has his or her first angina symptoms, usually after exertion or other increased demands on the heart. Variant or Prinzmetal's angina is chest pain or discomfort resulting from coronary artery spasms and typically occur after rest. Pre-infarction angina refers to chest pain that occurs in the days or weeks before a myocardial infarction. Please pause this video and click the link on your PowerPoints to view a TED Ed video about myocardial infarction. The most serious acute coronary syndrome is myocardial infarction, often referred to as an acute MI. Undiagnosed or untreated angina can lead to this very serious health problem. Myocardial infarction occurs when myocardial tissue is abruptly and severely deprived of oxygen. Ischemia can lead to injury and necrosis of myocardial tissue if blood flow is not restored. There are two types of MI, non-ST segment elevation MI or a non-STEMI, and ST elevation MI or a STEMI. Patients presenting with non-STEMI typically have ST and T wave changes on a 12-lead ECG. This indicates myocardial ischemia. Initially, troponin may be normal, but it elevates over the next 3 to 12 hours. The combination of changes on the ECG and elevation in cardiac troponin indicates myocardial cell death or necrosis. It is important to note that changes in ECG along with elevation of troponin should always be assessed in conjunction with the clinical presentation and history of the patient. Patients with elevated troponin and ECG changes without typical symptoms of acute coronary syndrome such as chest discomfort, shortness of breath, and nausea typically have a condition other than CAD, such as sepsis, causing an imbalance between myocardial oxygen supply and demand. Causes of a non-STEMI include coronary vasospasm, spontaneous dissection, and sluggish blood flow due to narrowing of the coronary artery. Patients presenting with STEMI typically have ST elevation in 2 contiguous leads on the 12-lead ECG. This indicates MI and necrosis. STEMI is attributable to rupture of the fibrous atherosclerotic plaque leading to platelet aggregation and thrombus formation at the site of rupture. The thrombus causes an abrupt 100% occlusion to the coronary artery in a STEMI. This is a medical emergency and requires immediate revascularization of the blocked coronary artery. Infarction is a dynamic process that does not occur instantly. Rather, it evolves over a period of several hours. Hypoxemia from ischemia may lead to local vasodilation of blood vessels and acidosis. Potassium, calcium, and magnesium imbalances, as well as acidosis at the cellular level, may cause changes in normal conduction and contractile functions. Catecholamines, such as epinephrine and norepinephrine, released in response to hypoxia and pain, may increase the heart rate, contractility, and afterload. These factors increase oxygen requirements in tissue that is already oxygen deprived. This may lead to life-threatening ventricular dysrhythmias. Obvious physical changes do not occur in the heart until 6 hours after the infarction, when the infarcted region appears blue and swollen. These changes explain the need for intervention within the first 4 to 6 hours of symptom onset. After 48 hours, the infarcted area turns gray with yellow streaks of neutrophils as neutrophils invade the tissue and begin to remove necrotic cells. By 8 to 10 days after infarction, granulation tissue forms at the edges of the necrotic tissue. Over a 2 to 3 month period, the necrotic area eventually develops into a shrunken, thin, firm scar. Scar tissue permanently changes the size and shape of the entire left ventricle, called ventricular remodeling. Remodeling may decrease left ventricular function, cause heart failure, and increase morbidity and mortality. This scar tissue does not contract, nor does it conduct electrically. Thus, this area is often the cause of chronic ventricular dysrhythmia surrounding the infarcted zone. The patient's response to an MI also depends on which coronary artery or arteries were obstructed and which part of the left ventricle wall has damage. Obstruction of the left anterior descending artery causes anterior or septal MIs because it perfuses to the anterior wall and most of the septum of the left ventricle. Patients with anterior wall MIs have the highest mortality rate because they are most likely to have left ventricular failure and dysrhythmias from damage to the left ventricle. The circumflex artery supplies the lateral wall of the left ventricle and possibly portions of the posterior wall or the SA and AV nodes. Patients with obstruction of the circumflex artery may experience posterior wall MI or lateral wall MI and sinus dysrhythmias. In most people, the right coronary artery supplies most of the SA and AV nodes, as well as the right ventricle and inferior or diaphragmatic portion of the left ventricle. Patients with obstruction to the right coronary artery often have inferior wall MIs. About half of all inferior wall MIs are associated with an occlusion of the right coronary artery, causing significant damage to the right ventricle. Thus, it is important to obtain a right-sided ECG to assess for right ventricular involvement. Atherosclerosis is the primary factor in the development of coronary artery disease. Numerous risk factors, both non-modifiable and modifiable, contribute to atherosclerosis and subsequently to coronary artery disease. Non-modifiable risk factors include age, gender, family history, and ethnic background. Age is the most important risk factor for developing coronary artery disease in women. The older a woman is, the more likely it is that she will have the disease. Heart disease is the leading cause of death in women. Several groups have higher genetic risk for coronary artery disease than others. For example, African American and Hispanic women have higher coronary artery disease risk factors than white women of the same socioeconomic status. Please review Chart 38-1, Patient and Family Education for Preventing Coronary Artery Disease. Modifiable risk factors include serum cholesterol levels, cigarette smoking, hypertension, impaired glucose tolerance or diabetes, obesity, excessive alcohol, limited physical activities, and stress. Metabolic syndrome has been recognized as a risk factor for cardiovascular disease and is being researched aggressively. Risk factors for metabolic syndrome include hypertension, decreased HDL, usually with high LDL levels, increased level of triglycerides, increased fasting blood glucose, and large waist size. Patients who have 3 of the factors that were just listed are diagnosed with metabolic syndrome. 95% of sudden cardiac arrest victims die before reaching the hospital, largely because of ventricular fibrillation or VFib. To help combat this problem, automatic external defibrillators or AEDs are found in many public places. Health promotion efforts are directed towards controlling or altering modifiable risk factors for coronary artery disease. For patients at risk for coronary artery disease, especially MI, assess specific risk factors and implement an individualized health teaching plan. Teach people who have 1 or more of these risk factors the importance of modifying or eliminating them to decrease their chances of coronary artery disease.